So I'll go a little quicker and really hit the high points because we've already established that LAI treatment is important. So basically, we were asked to summarize the reasons for and against long-term treatment in this World Psychiatry paper, and said, yes, we need to do long-term treatment because more symptoms beget more symptoms, more suicides. The gray matter actually shrinks with each relapse. There's 1 in 6 to 1 in 7 people who will not respond as well anymore as they did before, and greater cost and burden to healthcare systems, families, and caregivers. We do know that people who are considered treatment resistant, a third of them actually have blood levels that are subtherapeutic, and a third of them have 0 blood levels, even though they're in the IOP in London in the treatment refractory clinic. So that's why when we put our guidelines together, we said that maybe a long-acting injectable should be part of this. Can we prevent relapses? Yes, we can with antipsychotics with an NNT of 3, which is enormous. Obviously, continued treatment doesn't give people a job, so we need to rehabilitate them using that stability. We've discussed that in the first talk. And yes, medications have more side effects than placebo, but we have different levels of side effects, particularly with the medications that have come to market. Very strange finding initially. The longer the treatment lasts, the smaller the difference to placebo, the closer to 0 it gets. Why in long-term treatment less efficacy? Well, you know it because the longer you have to take something, you don't anymore. And that's seen here, that the LAIs reduced versus placebo relapses down to 1/3, whereas in the oral treatments only cut it by half. So LAIs are really important. This is from a paper where we summarize the different pharmacologic and also usage patterns of LAIs. What has come in addition, and I added this to the table, is basically that we now have the first subcutaneous risperidone once monthly per Ceres, which is injected into the abdomen. We have our aripiprazole Laroxel Initio, which is before we had with our aripiprazole Aristada a 3-week oral co-treatment needed, and with Initio you get 1 dose of 625, I believe it is, and 1 dose of 30 milligrams oral, and you're done. But you need 2 injections. You need the regular one, which builds up over 3 weeks, and then you get this jump start. What's in the hopper is the 6-monthly formulation for paliperidone. The studies are being completed. At the moment we have obviously, as you know, once monthly and 3 monthly, but there will soon be a 6 monthly, and the other agents is only studied in Europe at the moment, and there will be more subcutaneous treatments coming down the pike. Another risperidone, which I think is superfluous, is currently being studied, but hopefully there will soon be olanzapine, that is a subcutaneous agent, which you know has this problem that is very water and blood soluble and can lead to sedation, somnolence, coma syndrome if you inject all of it into the bloodstream. And they're also looking into lurazidone and other agents, because with sub-Q you might be able to formulate agents that were not usable deep injectable. Brexpiprazole they're looking at, a long-acting injectable, and lumateperone, the agent that is coming out next year, they're also already looking at sub-Q. Okay, our LAI is better than oral treatments. This is our first meta-analysis where we, to our big surprise, were not able to show it, but the reason was that people who are in RCTs are adherent. So you don't see basically a difference. You need to look at real-world patients. So our second meta-analysis showed in mirror image studies that use the same patient as their control, which is what we do in clinical care. We don't compare Mr. Miller with Mr. Jones. We call Mr. Jones and change something and look before and after. And here we were able to show very strong reduction in hospitalization by 57% for the first relapse, and for 62%, even stronger for multiple relapses. So our multiple service users are even benefiting more from LAIs. Why? Because when people are switched to an LAI the 12 months before, and you look at their pickup rate from the pharmacy, they only have 40% of time the medication in hand. Doesn't mean they're swallowing it. And that obviously doubles almost when you go to an LAI. Our last meta-analysis that I don't think was ready yet when we had the last review followed also This study, which is what I already showed, the best hospitalization reduction was seen with LAIs. Actually, there was a 20 to 30% lower hospitalization risk in real-world settings when patients got LAIs versus oral treatment. And this is the cohort study meta-analysis, where again we showed people who in real care, usual care, get an LAI, they are sicker. So having the same hospitalization risk would be actually, I think, already a win. But for multiple hospitalizations, we can already see a difference. Yes?
When you say LAIs, are you talking 1 injection, 2 injections, 3 injections? At what point do you start?
Yeah, so this is somebody who's starting on an LAI or starting on an oral, and then you see what happens over time. Obviously, there is a break, there is a rate of people discontinuing LAIs. That's a problem. So this meta-analysis did a very nice event-based assessment where they used the same patients as their control. So they compared the same patient when they had LAI phases or oral phases and didn't have two groups. And with that, you're again controlling for some cohort effects and biases based on selection. So this is pretty good that when the same patient was on oral or on LAI, basically the LAI phase had lower relapse rate and hospitalization. But obviously guidelines are informed not only by cohort studies, they are informed by RCTs, and we now know that the groups that are at highest risk for relapse, they even in RCTs show a good effect. And one is people who have been in conflict with the law or substance abusers. This was a paliperidone study where, yes, there's big treatment failure in both groups, but still significantly less with the LAI versus oral treatment. And early phase patients, patients who are early in their treatment course. Here we have patients within 5 years, they can pick any oral treatment which favors the oral treatment because you can pick the right one based on prior history of tolerance and efficacy, but still there was a 30% lower relapse rate when people got an LAI. And this study is the most powerful one. Patients with first episodes get either the same medication orally, oral risperidone or LAI risperidone, and observed after 1 year, 1 in 3 or 5 out of 100 have a relapse. If you had a brother, a cousin, a sister, a mother, would you want 1 in 3 or 5 out of 100? But look what happens, what am I talking about, 33% is here. When you do a Kaplan-Meier curve and observe everyone for a full year, it's 1 out of 2 versus 8 out of 100. That is 600% reduced rate of relapse and a 42% absolute risk difference. And we're still prescribing mostly oral treatment, 8 versus 50%. That is enormous, and especially in first episode patients who have the most to lose and the most to gain, and who obviously say, oh, I don't have the illness, and they are silent when they stop because the families are very concerned, we're concerned, and nobody tells us. And the reason here why this is big difference, excellent adherence, 33% on oral, that means this will go to 70%, but 95% on the LAI. Why 95%? Do the patients suddenly say, yes, I have the illness, please give me the needle, I love it when it penetrates the skin, I want the sedation, the sexual side effects, the weight gain, here I am. Of course not. They also say, leave me alone, I want to smoke my marijuana, but the moment they do, everybody knows, and that is the secret of the LAI, yeah? That it's a treatment indicator as much as a treatment itself. And when people stop, you have a broader window of opportunity. This is a complicated slide because it's placebo arms after stabilization and stopping oral paliperidone, once monthly paliperidone, or 3 monthly paliperidone. With a once a week washout phase, once a day half-life, after 60 days, 50% had to be removed because they got worse. 60 days. This extends after stopping the LAI, the once monthly, to 7 months. So you have much more time to get people back in care, and when people stop the 3 monthly, 50% are relapsed only after 13 months. So again, a big additional advantage when people stop. This is a paper that we published to say, well, but what do you do when people have psychosis on the LAI? Yeah, because that can happen too. Do you give up? What do you do? So what we basically recommend is, first of all, rule out what could be the contributing reason. And we might be able to put something into, maybe even this algorithm into the guidelines. I haven't put that in yet. But rule out, this could be substance abuse, this could be medical illness. Are there any stressors you need to address with non-pharmacologic treatments? What about comorbidities? Proper administration. Is it really deep intramuscular, or is it oozing out into the fat cells? Also, when you schedule the patient always on time, they can never come early. They come on time or late. You might accrue always late, 3 days here, 4 days there. So in order to compensate for that, you might actually have to get them in earlier in order to catch up and not over time lose your blood level. You might want to increase the LAT dose at the next level, but what if you are already at the maximum dose? And then we were able to put this in as clinical consensus. If you're at the maximum dose and this is a patient who needs more care with the medication, we would add the same medication orally under supervision, and if they're tolerating it and get better, then you might shorten the interval in order to get higher blood levels, because obviously patients might be ultra-rapid metabolizers or whatever. So this might be something we could put in. And then you obviously get the oral co-treatment with the same medication, and you would stop it if people get better. If they don't get better and the symptoms recur, you go through the exact same algorithm, and if it doesn't work, then you might switch to either another LAT or another oral treatment. But I think that's important for people to consider, and if you wanted to use that algorithm in the guidelines, you could. LATs are at least as safe as oral medications. Side effects are generally not higher, and we're currently finishing a mega review of 662 cases of NMS, neuroleptic malignant syndrome, and show that sequelae and death are not higher if they occur during LAT use than oral use, because it's symptomatic treatment. There is a longer phase of NMS, but it's only 2 days, and it doesn't translate into more hospitalization. Again, we haven't written this up yet, but just to give you a backdrop that we're not recommending anything where people would die more. And that's also, death was, in this meta-analysis that we did, not higher with LATs than LAIs. But death is obviously the ultimate side effect of life, yes?
Just going back to breakthroughs for a second, is breakthrough most common at the very end of the 4 weeks?
Generally.
What you're finding?
Generally.
Yeah.
That's also important. I don't know whether we put this here, but you know that in the deltoid you get higher levels but shorter half-life because you have a small compartment. In the gluteal muscle you have lower levels but longer half-life. So if you have an end of injection interval worsening and you're in the deltoid, you want to go down. Because here you have longer half-lives. That's why with paliperidone you start here because you want to jumpstart the therapeutic level. So some people might not know that, and let's see whether we can put something there if worsening at end of injection interval and you're not at the gluteal muscle, go there.
One other question. The dropout rate after the first shot, do you have any idea about the dropout, or what percentage?
I don't know after the first shot, but Mark Olfsen has done some analyses in the US where the mean duration was only 180 days. Yeah? So people also stop again LATs. That's a problem. We don't fully understand why.
So when I go out to meet with mental health centers, I suggest, you really have to be careful about the dose, because the worst thing is that the patient have an LAI and have bad side effects from it. Then they never want to take it again.
I fully agree. That's why I want some oral phase where I can be safe to give them something. I don't want to lose them just because I saved 2 weeks. I fully agree with that, yeah. So this is the paper that was rated one of the 10 most important papers in 2018 during the ECNP, the European College of Neuropsychopharmacology meeting, because it shows 2 things. One, people who are not on antipsychotics die the fastest, and not only of suicide but also of cardiovascular illness, even though they don't take medications that increase weight and metabolic problems, because they have psychosis, which increases inflammatory markers. They are so sick that they have poor healthy lifestyle and they don't go to doctors. The second worst outcome, again, 100% available patients in Sweden over this period of time. Nobody dropped out. It's fully generalizable. The second worst was first generation antipsychotics, correcting for baseline differences. The best was second generation, but the very best was long-acting injectables because they were assuredly on treatment. And if you, this is a cool figure, if you prescribe an oral medication and it is picked up from the pharmacy, your risk of death is set as 1. If the same medication is prescribed orally but not picked up from the pharmacy, the risk of death is increased by 25 to 75%. If the same medication is not prescribed orally and picked up, but who knows whether they take it, but prescribed as an LAI, you have a 12 to 51% decreased risk for death. So the death rate was decreased by 20 to 30, by basically 30% if you give an LAI versus an oral treatment. That is, I think, again, now another argument. Not only is there less treatment discontinuation, and you see when it happens, not is there only less relapse and hospitalization. We now know you can live longer when you get an LAI. And this was data from 6 years of follow-up. We now have in press with Yari's group together this 20-year, the FIN20 study. You may know the FIN1120 study was published in JAMA. This is now World Psychiatry, where again, people on antipsychotics, we didn't have the difference, this is Finland with the LAT, but antipsychotics in general also have a significantly decreased mortality rate. So we do want to do long-term care in people with schizophrenia. Last argument, how do you offer LATs? Who's in the way of offering it? It's us, it's not the patients, because we overestimate what patients have against LATs. This is a study from Norway where doctors and nurses always overestimated by 20 to 40, 50% the problems patients might have with an LAT, stigma, feeling controlled, less dependent, embarrassed. But the only part where they underestimated the counter-arguments patients had was having to stay in the hospital after olanzapine injection. People don't like to stay in the hospital, even in the outpatient setting. How do we offer it? We offer it with 9% of benefits mentioned during the speech time, the elevator or the office speech. The rest is either neutral or negative. So what did we do? We have a big, and that's the last 2 slides, a big cluster randomized study of early phase and first episode patients, 500 of them, who were randomized, cluster randomized to 19 sites having name of the game. We give you an LAT after you start oral treatment. This is what we do, or usual care. And you know, for first episode patients, it's basically 5% get maybe an LAT, maybe 10. In order to win in a cluster randomized site versus site design, we said we need to bring this up to 50%. Every other patient, first episode or early phase, needs to get an LAT. So what did we do? We invited the entire team, case managers, doctors, nurses, psychologists, everybody. And we gave them talks like this and then did role play on the stage. What do you do when people say yes or no? What do you think? What percentage of patients got at least 1 shot? First episode in early phase patients.
85, 91.
Wow, you've seen the paper. It is 91%. It is amazing. How do you do that? Okay, 14% said, I don't want to talk to you anymore. We couldn't work on them. This is within the first 3 months of being in the clinic. But if you subtract 14 and 9, 3 out of 4 patients got at least 1 injection. And it's in the US, it's 10% of all people, even chronic people, even people have shown already that they're non-adherent. 91 when we can talk to them. So yes, we can. We're now analyzing the data of relapse. It's a 2-year study, and how long they stayed on it. That they just get 1 shot and then stop. But at least we can. Okay, so I think LATs have a lot of advantages, which is why we should use them. That's the bottom line.